Many thanks to all of our presenters today. I'm now going to start the Q&A session. I'm glad to say that we've had quite a few questions coming in on the chat, and what will happen is that Cheryl and I will read out the questions, and we'll also suggest which of the speakers may want to address the question first. If you have follow-up questions, please put them in the chat and we'll try to get to them if we can. You may have noticed that we're running a little bit behind schedule, but we're definitely going to try and allocate enough time for as many questions as we can. So the first one that we had was a question about progression. So this will go to Professor Koschmider first. The question was, could you give us some indication of the success rate of stem cell transplants if that was carried out after progression to acute leukemia?
Sure, sure, I'm happy to. Hello, everyone. Can you hear me okay?
Yes, we
All right,
can.
thanks a lot. Yes, so I think generally survival is poorer, we have to say, at the blast phase or acute phase MPN stage, even after allogeneic transplantation. And so that's why we do not want to wait for progression to the acute leukemia stage, but rather closely follow the patients during the MF stage and then transplant if we need to. There are certain things that are important even in patients that have progressed to acute leukemia that we know we should try to achieve. So one of them is that we will try to achieve a remission, meaning to take the acute leukemia phase back to a myelofibrosis stage or even a better stage before we transplant, and that can be done using chemotherapy, for example. But we also know that certain genetic factors are important, so we will try to take a look at those and direct our treatment and the type of treatment towards these genetic risk factors as well. But this is really ongoing research, and it's highly individual, as I highlighted before. So it's very important that this is done at a large care center where the allogenic transplants physicians have lots of experience with transplants.
Thank you so much, Professor Koschmider. Our next question is directed to Dr. Ruben Mesa. It comes from one of our attendees, and they've asked, can high white blood count be seen as a sign of progression? Or how would you, if you had a patient come in, what would you discuss with them in regards to the possibilities or opportunities of progression for a PV or ET patient to MF, or perhaps an MF patient to AML?
It's an excellent question, Cheryl. As for many MPN patients, it's the issue of progression that truly takes the disease from being problematic to potentially life-threatening. But with ET and polycythemia vera, I think that evidence of progression can be with changes in the blood counts, typically from being high to being on the low end, although increases in white blood cell count can be associated with evidence of progression in ET or PV, particularly above kind of their baseline. Second, a growth in the size of the spleen, particularly to be significantly below the rib cage, is a concern. And third, changes in the pattern of symptoms. So particularly the onset of inadvertent weight loss, night sweats, fevers, bone pain, frequently much more associated on the myelofibrosis end of the spectrum, sometimes worsening fatigue. Now, amongst myelofibrosis patients, progression, particularly toward acute leukemia, can be sometimes associated with significant increases in the white blood cell count, particularly if values well above 20 to 30,000. But as I start to see values of 50,000, 70,000, 100,000, I do get significantly concerned about a change in the biology of the disease. But other features, the makeup of the white blood cells or the composition by the differential is very important as well. So progression toward blasts in particular are very concerning, with values of even 10%, in the peripheral blood being very concerning of eventual evolution toward acute leukemia. So we're still learning more about progression. It's a key issue for us to understand and how to measure in trials. But overall, for the questioner, increases in white blood cell count, particularly above values of 20,000, can be a sign of significant concern.
Great, thank you so very much for that excellent information to our patient advocates group. Dr. Vanucki, or Professor Vanucki, I have a question for you, given by one of our attendees. How important do you consider the control of the portal vein in order to avoid hypertension of the same and to prevent Budd-Chiari's disease or syndrome?
Well, this is an important question because we know that this kind of abdominal thrombosis is quite rare in the common population, but is quite enriched, definitely enriched among patients with MPNs. And this is especially a kind of manifestation that is typical of young women. It's definitely, there is definitely an increased rate of this kind of thrombotic events in women as compared to men. And the approach to these has been definitely improved in the last years following the discovery that more than 60% at least of these thrombotic events in this kind of young women are associated with an MPN. And this was not so clear before the discovery and the clinical use of a JAK2 mutation. And so these patients are to be considered even if their blood counts appear to be in most cases within normal range, because that is the case. And this makes diagnosis sometimes difficult, where these have to be considered as MPN under any kind of respect. So the management of this patient is of two directions. One is to control and manage their MPN, and the other is to control and manage the impact of the thrombotic event on the liver, on the bowel, and so on. So we need here to have two specialists. One is the hematologist expert in MPN, and the other is the hepatologist expert in thrombotic events of the abdomen. So we have learned since recent studies that in these patients, the most important approach is to control coagulation. And so these patients should be anticoagulated. At present, we could recommend for their lifelong life. While the impact of cytoreductive treatment is less clear, and for those patients who might require it, interferon might be definitely the first option. Also consider that most of these are young women.
Great, thank you so very much. John, I think you have a question?
I do. So I think this is for Ruben, but I'm sure the rest of you will have some opinions as well. So one of the slides that you presented early in your presentation showed the amazing variety and, as you said, depth and breadth of research into therapies, new emerging therapies for MPNs. The question is this, though: as a clinician, and you had a patient with a particular presentation, is there a particular approach that you would recommend for directing them to or away from particular trials that they may be eligible for?
That's an excellent question, John. I think as one think about clinical trials, they really fall into different categories. So one, there are trials where we're trying to build already on something that we know is effective. So for example, now there are several trials that are considering adding a second therapy onto starting with a JAK inhibitor in myelofibrosis. So the base of the treatment remains the standard of care. Or let's say it's interferon plus something else in polycythemia vera. So you're starting from the standard of care so that, you know, the downside of participating in the trial, you know, is potentially less, because at a minimum you're getting the standard of care. So that's kind of group one, and that, you know, I'd encourage anyone to consider a trial that's kind of appropriate for their situation with the disease, because in all trials we aim, and we're ethically bound as we report to our own institutional ethics boards, that the trial we're offering should not be inferior to the sort of care that the individual should receive otherwise, so that there shouldn't be a big downside. The second group of trials are ones that are truly more experimental, where now the individual has no longer benefited from the standard of care, and they're receiving a completely new medication because they've either failed a JAK inhibitor, or they've failed what have you, or they're going to stem cell transplant, but on a trial. So that's a little different because there is no standard of care. Those can be a bit more complex because individuals may have more than one option. They may have an alternative that their physician can prescribe, but there may be pluses or minuses to that, or a clinical trial. And in there, again, I encourage people to consider them, but obviously you have to be mindful of, you know, what is the time, the commitment, the hassle, or the potential side effects of participating in the trial. But take away, not all trials are really the same in terms of how experimental they are. The most experimental are the ones that we call phase 1 trials, where it's the first time a drug has ever been tried in human beings. So you might be on one of those experimental trials for a second-line therapy, but it might be for, it's already been used in, you know, 50 or 100 or 300 people. The phase 1 trials are truly where no one has ever received the drug before, and we're really trying to see whether it has safety and effectiveness.
Thank you very much, Dr. Mesa. I have one question here that's been posed to us by some of our attendees, and it's for all of you to all chime in. And so we know that there's a dichotomy of how patients are treated and unmet needs across the world, but yet all MPN patients have the very similar burden of the disease no matter where they live. How do we get patients and their physicians discussing the information that you presented today? How can patients, what advice can you give to our patient advocates to give to their patients in how they can stimulate the discussions with their physicians in treating their MPN diseases around the world? How can we encourage that? So Professor Koschmieder, we'll start with you on this question.
Sure. I think this is a pretty difficult question because it involves not only medicine, but it involves politics, involves lots of money, and of course, different settings. And I think the three of us would probably agree that that we would love to have more clinical trials, easier access to the clinical trials, easier access to novel therapies. I think this kind of meeting is exactly what is needed to get the conversation going. But it will eventually rely on talking to physicians, but also politicians in the different countries to enable these trials to be run in hopefully any country.
Professor Vanucchi? Oh, sorry, Dr. Mesa? Oh.
Alessandro, please.
Oh, okay, so we remain in Europe, and just remaining in Europe, I'd like to mention the fact that at EMA, that is the organization that takes decision about drugs in Europe, there is a rising role of groups of patient groups that are included in the evaluation of new drugs when they are close to the approval, because of course the voice of the patients, and since the knowledge of the patient has definitely risen in the last years, where the voice of the patient must be heard not only by the physician, but especially by the politicians. And as Stefan mentioned here, the issue is that, of course, also of money. There's a lot of money behind the use of new drugs. And so what I think is that new drugs should be made available to all patients, but there must be also an experience from the prescribing physician in order to use at the best the supply of these drugs, in order to use at the best the public money. Because it might happen that in some cases, the choice of the drug towards the other may be dictated just by the favor of the physician, the willing of trying something that is new, but not always this is maybe cost effective. And so I think that this is really like the Janus kinase that has two phases. One is everything for the patient, and this is right, but at the same time use the right things for the right patients. I think this is personalized medicine that involves a lot of discussion about patient, physician, politicians, and money. Ruben, that's for you.
So I was going to add in a slightly different direction, in that, one of the things I took away from your question, Cheryl, was a bit regarding how do they help to improve communication between patients and their physicians, regarding some of these issues and therapies. And it's a challenging one because of both cultural parts, where again, in medicine, I think we are at an evolution, but in much more evolving to shared decision making versus the history of medicine, where it had been very paternalistic. The physician prescribes and the patient has to, do whatever is said. I do think that it's important to realize that in the workflow in a standard physician's office, the amount of time the physician really has kind of allocated for that patient is sometimes fairly modest, and they may not, off the cuff, really have, good knowledge of, the latest trial data from CPI 0610. They're trying to undoubtedly keep track of many diseases. If you're lucky, just hematologic malignancies, as they would in Italy, but in Germany, they may also deal with solid tumors, as they do in the US. So my suggestion, as I've given patients over time, is to either signal ahead to the physician, as that there's frequently ways to do. At our next visit, I would like us to discuss whether I should be an candidate to interferon, and I'm interested about, drug X or whatever that is. Or if they, see them at one visit, say, when we visit next, I really would like us to discuss me going on therapy because I'm getting very tired of phlebotomies. So signaling that ahead, and again, if you want your doctor to really take a look at one particular option, giving them a heads up so that they can look into it in greater depth will be very helpful. I mean, if you go to Stefan or Alessandro, yes, they know this data off the top of their heads very well. But that's really an unrealistic expectation for many hematologists. It'd be the same if you came to me and asked me about a new myeloma drug. I won't be familiar with it. So I think it's to be fair, that communication really signal ahead to folks, and then don't expect your physician just off the cuff to sometimes have an answer.
Great, thank you so much.
That's great advice, Ruben. Thank you very much. Okay, guys, that's been amazing. Thank you so much, not only for your presentations, but for your attention to the questions and your very succinct and thoughtful answers. So now for everybody else, we're going to take a 15-minute break. Please continue to put questions in on the chat function, and we will either try to address them live today, or if we can't do that, we will make sure that they get answered in one form or another after the event. So I think we're just going to take a pause now for 15 minutes, and we'll be back at about 20 minutes past the hour. Okay.
And